Does anybody else feel like they're at a wedding? I don't know if it's like the white chairs or the family feeling, or I don't feel like I'm at a work conference. I a little bit feel like I'm at a wedding. All right, so I'm going to talk a little bit about implementation of the Zero Suicide Program process metrics across all the different Kaiser regions. So Julie was talking about one of our regions. I'm going to kind of take a step back and look at all the different regions. So in the first aim of the grant we worked on with Brian, we did key informant interviews to try to understand within each of these systems which zero suicide practices the systems were going to take on, because they weren't going to do the whole model, right? That was a bit overwhelming, but they did an assessment at the Zero Suicide Academy, and they chose things that they wanted to work on. And the main take home here is that the identify and engage components of zero suicide were where most of the effort went. So that is screening with the PHQ-9, the Columbia, and then safety planning. So some of the practices that changed included implementation of the Columbia in primary care, also implementation in the mental health setting. So as Brian mentioned, that was going to happen across all the settings, whereas implementation in primary care was a little bit more sporadic. There's also this shift towards more standardized safety planning using something called the Stanley Brown Safety Planning Intervention. And just so who has heard of the Stanley Brown Safety? Okay, so, all right, so good familiarity. All right, good. There was a little less enthusiasm in the treat and transition areas and for zero suicide. Not that our systems weren't doing these things, they were. There just was less enthusiasm in terms of focusing on them to change something. For the treat component, it's very hard to see from our electronic data what is actually happening in a session with the patient. So we can see whether a session happened, but not like was suicide directly addressed. So there was less enthusiasm there. And then in transitions from inpatient to outpatient, there was already a ton of stuff happening. So I'll show you some measures, but I just want to mention, like, we didn't expect to see a lot of change there because that wasn't the focus. It was really in this identify and engage area. So I did a supplement to the grant that Brian did to really hone in on our methods for measuring safety planning. And so prior to this more standardized implementation of the Stanley Brown that happened, all the systems told us, we're doing safety planning. We said, okay, what are you doing? And everyone told us something different. So there was, okay, well, safety planning looks pretty different in these different places, and we needed to understand what was happening. And so we did a chart review, and we looked for each of the different components of the Stanley Brown in the chart to see what was actually happening. And what we saw was that safety planning really meant you got professional context for help, you got lethal means counseling for firearms, most likely, you maybe got some lethal means counseling for medications, and that was pretty much about it. There wasn't sort of these other practices happening until we had more robust implementation with the Stanley Brown. So we developed these natural language processing programs. That's just sort of a fancy term for being able to read clinical text and categorize it. And so we developed these programs to be able to measure when these practices were happening. And then we validated those programs. And so what you're looking at here is the accuracy of us being able to measure when firearm counseling was happening, when medication counseling was happening, and when professional contacts were happening. And so we did a pretty good job to be able to accurately identify that from the clinical text. When it comes to measurement, anything that's documented in clinical text is hard to find. It's hard to measure versus like a screening score. So then comes along the Stanley Brown. So this is the template that was implemented within Kaiser. And as you can see, there are fields for each warning sign, for each coping strategy. And this is great for the future because now we can measure what's happening. We can see the content of these safety plans now. And so this is really exciting going forward that we'll be able to evaluate, does things like quality of safety planning impact suicide rates? So just more of the template here. And one more thing I want to mention, in that step 6, the making the environment safe, there's a lot of variation in how that was implemented across the regions. So some of them have these very specific prompts, like, are there guns in the home? Have you stockpiled medications? Whereas others just have a very open-ended sort of like lethal means counseling section. So it'll be interesting to see if that changes how lethal means is delivered, depending on how it's prompted. Okay, so I think this is sort of the meat of the presentation. These are the process metrics that were decided upon between our research team and the health system leaders. And so the first two aren't going to surprise you, as Brian was talking about. The PHQ-9 item 9 was supposed to be delivered in all behavioral health appointments and then once a year in primary care, followed by the Columbia within 2 days if that item 9 was positive, and then going on to the engaged measures, which we developed with the NLP programs, lethal means counseling and safety planning. So we defined this minimum safety planning measure, which was lethal means versus professional contacts, and then a better measure, which was the Stanley Brown. We also had some measures for treat and transition as well to look at follow-up appointments after a risk was identified. So getting into some data. So this is the population reach for screening. So this is all covered lives by these insurance companies. This is not people that actually show up for visits, which I'm going to show you on the next slide. It's really easy to make a difference when people are in your office. It's harder when it's just a whole population that may or may not ever come in for a healthcare appointment, especially younger, healthier people, right? And so what we're excited to see is that before Zero Suicide happened, less than 10% of people were ever screened within a year for suicide ideation in these systems. And then after it was implemented, the top performing site got up to about 36% of their entire population was screened for suicide every year. Here we look at what happens when people actually come in for visits. So the denominator here is not everybody, it's just those that have shown up for a visit. And so A, B, C across the top is the mental health setting, and then across the bottom is the primary care setting. So starting with A, we're looking at screening with the PHQ-9. And we see after Zero Suicide implementation, this nice increase in terms of more people getting screened at their visits at most of the systems. Once people were identified at risk, we see an even better sort of performance on did they get the Columbia. And then from there, we see that most people that got the Columbia and had a high score are getting means counseling, and there's just a nice increase over time. Now, down to D in primary care. Some room for improvement. We see that in primary care, one of the sites did quite well in terms of screening every year, and the other ones still, well below 10% of our primary care patients were screened every year. Once risk was identified, though, they did a pretty good job of risk assessing and delivering means counseling. The Stanley Brown template, when we look at how that was implemented across the systems, some of them took it on, and you can see that here, and others just kind of tried it and said, no, we'll go back to our old safety planning. So there was definitely some variation. And so a fidelity across all 6 systems in 2019, we see in the identify area pretty good screening rates in mental health specialty, a little bit lower, about lower in primary care, but then once they're identified, we'd see a pretty good risk assessment rate. As far as safety planning and lethal means, those rates were quite high, and this is quite higher than I've done some work in this area in the past, and we only see about 30% of patients prior to this that are receiving lethal means counseling, so going up to 80% is really an improvement. And then in the treat and transition, as I mentioned, we didn't focus on these areas, but we wanted to make sure we reported out on some metrics. In terms of healthcare encounters that were happening following identification of risk within 30 days, 66% of patients had a visit. And then for emergency visits, within 30 days, 71% of people had a follow-up visit. So overall, we can say we had pretty good fidelity to the identify and engage practices in the mental health setting, a little bit lower fidelity in our primary care setting, but good follow-up once risk was identified. And then for safety planning, we had very high rates of lethal means counseling and some variation in this more standardized Stanley Brown implementation. All right, I think I'm done. I'm going to hand it over to Sue. Oh, there you go. Oh, sorry, to Brian.
All right.